Today we're going to talk about vasopressors. This is a topic that a lot of nurses, nurses need to understand this. Critical care nurses especially, ER nurses also. But, this is something that we've noticed is not always really taught super well.
Definitely not in nursing school, and it's also really not covered in orientation. So we wanted to talk about something that we're seeing in our membership, the new to ICU membership, and just kind of have a conversation about vasopressors, why it's important to understand the way that it actually works, and then some kind of tools moving forward. So we're gonna dive into it.
Yeah, so for those of you guys who don't know us, my name's Chrissy. I'm a nurse anesthetist.
My name is Anna. I've been a travel ICU nurse. I am a first year SRNA, and I still work part-time, but we together have our education company, Confident Care Academy, where we're giving all of the new ICU nurses tools to succeed. It's a lot of pathophysiology, a lot of pharmacology, and a lot of case studies. But we also do a podcast, and today we're talking about vasopressors as we're diving into it. So one way that I hear new grads always talking about this is when they're asked, okay, well, what does Levo do? Like, what do they usually say?
Squeeze.
They're like, Levo is squeeze. And you're like, cool.
Squeeze where?
What?
Squeeze what? What is being squeezed?
What is squeezing?
What is squeezing, actually? Yeah, this comes up even in our mock interview stuff a lot of the time.
Yeah.
It's a presser and it squeezes.
Yeah, you're like, oh, and then oftentimes we won't even say vasopressor. You say it's presser. They say, oh, it's a presser and it does squeeze. And you're like, okay, well, and I think it circles back to like during COVID, new grads were training new grads. So the people who are training these new nurses or new critical care nurses,
other new nurses,
had a short orientation themselves.
This is still happening now. All of our new grads right now. So in the new to ICU membership, a lot of them are being trained by people who have been nurses for less than a year.
Yep.
And a lot of nurses are telling us, on social media, like, I've been a nurse for less than a year and I'm already precepting. And, since they did learn during COVID, like during a time when people were putting out fires, there was not as much time to like dive deep into these topics, not as much education on the unit. So, here we are catching up, but let's dive into it.
And I think it's part of why it's just important for you to invest in your own education so that you are going to be providing really good care. Diving into it, yeah. So what is squeezing? What are we talking about?
What is squeeze? So, in order to understand what is being squeezed, what do these drugs even do?
Mm-hmm.
I think the most important place to start is, first of all, you need to know the receptor site that it binds. And another oversimplification that I think is very common in ICUs, and I think is to the detriment of the knowledge of the ICU nurses, is that these drugs are often summarized with the main receptor site that it binds for the sake of not overwhelming you. Yeah, simplicity, not overwhelming with too much stuff. And I think that a lot of the nuance is lost, and when you get into critical thinking and understanding complex disease processes and why multiple pressors and how to wean what when, you don't understand the full scope of the drug, and so you don't know why you're doing what you're doing and how to advocate. So it's important that we know not just the main receptor it works on, but the other ones as well, and how binding occurs in a dose-dependent fashion. And all of the things that it does, all of the sequelae for good and for bad.
And this is where it gets into, unfortunately, as a new grad or as a new critical care nurse, you're just not going to learn everything that you need to know at work. During your 12 hours at work, you're going to be working on task management, you're going to be working on keeping your patient alive, and just activities of daily living, patient care. Yeah. You do have to study at home. You have to study at home. You need to come home and you need to review this stuff. But it is really, really, really important as we dive into vasopressors to approach it from a systems level. And by systems level, we're talking about the sympathetic and the parasympathetic nervous system, because you can't just say that Levo does squeeze. You need to say, okay, well, it works on these receptor sites, and that's why you're going to see these effects at X dosage and these effects at Y dosage. Because the thing is that was really lost on me as a new grad is that vasopressors don't do only one thing. Most of them do multiple things, and you need to understand what the medications you're using actually are doing to your patient at those receptor site levels. So like Levo, I feel like is a good drug to talk about, or a good medication to talk about if you wanted to talk about Levo a little bit.
So Levophed probably, Norepinephrine is the correct terminology for it, right? We should all be in the habit of not using the brand name.
Yeah.
That's like such an American thing to do. People from overseas always make fun of us for that.
That's fair.
Nobody does that anywhere else. Like, of course.
That's fair.
We still aren't doing metric either. Anyway, so, Norepinephrine is such a common pressor in the ICU. It's like the first line for sepsis, which is what happens to a lot of ICU patients. You're going to see it with your COVID patients. You're going to see it when patients are vasoplegic after, major
Surgery.
surgery.
Yeah.
You're going to see it in just all sorts of contexts. And the reason why do we love it so much? Which, you might have heard the old phrase, leave a fed, leave them dead back in the day. Older nurses still say that.
They do.
Was that passed down to you?
Yeah, it's kind of,
if I leave
the
it?
elder nurses would say
The
that.
elder,
yeah.
the elder.
There's no elder nurses left, but
Yes, they all left. That used to be kind of like a last line drug in ICUs, and it was kind of seen as like, at that point they're already dead. But now it's one of the first line agents that we use.
Yeah.
So why is that? It's really good. It works on a lot of different receptor sites. Primarily the one that you're going to have memorized if you're already an ICU nurse is
Alpha-1.
Alpha-1.
Yes.
Yes. So we love Alpha-1.
Alpha-1 agonist, which circles back to what's a catecholamine?
Before we get there,
You're right.
what is Alpha-1? What does that mean? Where is it? Where does it live?
Right.
So Alpha-1 receptors are primarily in the blood vessels, right? So arteries, arterioles specifically. And so what's going to happen with your Alpha-1 receptor when it's agonized? What's an agonist? Agonist means when it binds, it makes the thing happen, right? It's the lock and key model. Do you guys remember that from high school biology? The crowd goes wild. Yes,
Yeah, the lock and key. Yeah.
Agonist, right? Lock and key. You unlock the gate. Now we're going to have a series of different chain reaction of events. We're not going to get into that here. We'll be here all day. You guys can join us in the membership if you want to know more.
We'll have more there.
We'll have more there. But at the end of the day, the main take-home point is that calcium is going to get released along the way, and it's going to cause the smooth muscle in the arteries and arterioles to squeeze down, to constrict, exactly. And Chrissy, what is that? Did you just say the muscle in the arterioles? Yes, as a matter of fact, I did. There is muscle in your arterioles. Yes, that is how we have vascular tone and blood pressure. That's how we have squeeze. So, the primary mechanism of Levophed, norepinephrine, Alpha-1 agonist, it's going to unlock that mechanism. But why does that mechanism exist? What normally binds it?
Typically, the catecholamines that are produced in our own body, so as part of the sympathetic nervous system or your fight or flight when you're back in nursing school, you've got your adrenaline and your noradrenaline, which is synthesized by our own body in response to a stress response, or stress responses. Well, again, this is diet version.
Diet.
But it would be, so the norepinephrine is the synthetic, so man-made version of the noradrenaline, which is what our body makes naturally anytime that we need a little bit of extra vasoconstriction. So we are mimicking the body's own hormone and catecholamine release to make the vessel squeeze down. But most of these medications do more than one thing. And I think that's what was lost on me as a new grad, was that medications have more than one mechanism of action. They do more than one thing. So Levophed, we use it primarily for its Alpha-1 agonist properties, but it also does...
There's more. But no, more importantly, so, what's going to happen if you just have arteries squeezing down? What's happening to the heart? The heart is now having to pump harder to overcome that resistance, right? So what we really like about norepinephrine and why it's, resurged in popularity is that one of the other receptor sites it binds is beta-1. And maybe in nursing school you learn the shortcut, like one heart, two lungs. Beta-1 receptors are primarily in the heart. There are other places too. Beta-2 receptors are primarily in the bronchioles. There are other places too, but for the most part, broad strokes. And so when you bind the beta-1 receptor in the heart, you increase inotropy. So again, squeeze, but different type of squeeze, right? Not the same type of squeeze.
Heart muscle squeeze.
Muscle squeeze.
It's heart squeeze.
Heart muscle squeeze. So yeah, exactly. And again, chain reaction of events. So it's a beta-1 agonist. It's going to again unlock that receptor, cause the chain reaction of events, calcium release, muscle squeezing, and then the heart is going to pump harder. And that is going to give it the boost it needs to more efficiently overcome that extra arterial squeeze that you just caused, so that you're not increasing the workload of the heart disproportionately when you were helping out the blood pressure.
It's all about forward flow. You got to think about pipes and pumps, right?
Pumps.
Your blood vessels, oftentimes you think of them as the pipes. You often think of your heart as the pump. So Levo does both. Get you a medication that could do both. And a little fun fact, it also does have some effects at beta-2 as well. 2 lungs.
Yes, 2 lungs. So what happens at beta-2? That is going to be relaxation of the bronchial smooth muscle. So that is going to, primarily in like, let's say an asthma attack or a bronchospasm, when that smooth muscle in the bronchioles is constricting in order to relax open the airway, albuterol, right? That is a beta-2
agonist.
I'm like, wait a second, let me say
in nursing school, you learn it like SABA, LABA, like short-acting beta agonist, long-acting beta agonist.
That's cute.
And it's Levophed, it does it all. You've got your...
Levophed has some small effects there too.
Right.
You're not gonna have an asthmatic patient come into the ICU and be like, Levophed, let's go. But it's just good to know that the higher the dose, the more receptor sites it's going to saturate, and it's going to have effects at all of these receptors.
And I think that circles back to, for this video, where we are going to talk about the fact that your medications do more than one thing. So you just really, as a new clinician, as a new ICU nurse, having that kind of spirit of curiosity, that you're going to go and you're going to look up a medication, and you're going to not, like, really it circles back to just don't take what your preceptor says as the end of the line.
Yeah, don't take it as Bible. And even I sometimes say stuff wrong, and later I'll go home and be like, oh, I said that backwards to the student. I have to text them. I'm like, I lied to you earlier.
It was the opposite. It was actually the opposite.
I didn't have my coffee yet. You were a bad student. You should have brought me one. I'm just kidding. Yeah. What was I going to say? But it's also really important to know for understanding when not to use a drug, right? So this is a really common thing I see when I drop off patients in units that maybe they're dealing with a pathophysiology they're not super comfortable with.
Right.
A lot of times I'll hear nurses say to me, well, we don't use that pressor here. Okay, yes you do. You're just not used to it. It's like, yeah, you don't use that pressor here because your primary patient population, this one's more appropriate for.
Right.
But this patient today has this exciting thing going on, and this is more appropriate in this moment in time.
Right.
So, for example, a patient that should probably not have norepinephrine would be a patient with HOCM, hypertrophic obstructive cardiomyopathy.
Interesting.
So you think about how, in their case, especially if they have outflow tract obstruction, right?
Like pumping up against a wall, and that increases.
Yeah. So when the heart basically squeezes, and a patient with HOCM and SAM, systolic anterior motion, and they have outflow tract obstructions. There's a lot of words I'm throwing at you. I promise I'm gonna translate.
Here's word soup.
Basically, with the word soup, with this patient population, when it's severe, every time that the left ventricle squeezes, goes to eject blood into the body, there is a little bit of paradoxical motion where part of the mitral valve can get kind of sucked into the outflow tract and block some flow out to the body. So if you squeeze harder, you can make that suck down event worse and obstruct the outflow of blood even worse into the body. So normally when we have patients in heart failure, we think about epi and norepi, and we're helping squeeze. We want to help the squeeze more, and the patient's blood pressure's low, help squeeze. And we usually think, no fluid, don't give them fluid, fluid's bad, give Lasix, keep them dry, heart failure, dry. These are things that normally come to your head. In this patient population, it's the opposite. We want the heart to beat slow and full, so beta blockade is really important for them. Making sure their heart rate stays nice and slow, avoid tachycardia at all costs. A lot of times if the blood pressure is low, you're going to give a little bit of fluid.
Right.
And you're going to avoid a drug like norepinephrine because having extra contractility, extra squeeze, is going to make the outflow tract obstruction worse. So in this case, this patient is going to be on phenylephrine, which is something that maybe you haven't seen on your unit, or maybe you don't use very often on your unit. So it's really important to know these nuances of the drug so that when you have this patient, you can work your way through it and say, okay, this is not something I use every day. It's not something I'm 100% comfortable with it, but I see that it's important, so I'm going to take 5 minutes to talk to a NP and attending a senior nurse about this.
So with this, we're getting into heart failure in December, but this really reminds me of something that my preceptor did with me. Albert, love him. But the best way
Shout out to Albert.
But even if you're not a visual learner, if you wouldn't categorize yourself as a visual learner, get yourself a piece of paper and a Sharpie, and then draw out what it is you're talking about. So then you can really visualize where's the obstruction, what's happening, and what is it backing up into.
That's really great advice, just the practice of drawing things out.
Because then you really understand it as far as, especially with the cardiac system, it's always a forward flow issue to some extent. What's causing there not to be forward flow? What is the problem? And then when you can see where the problem is, then you can trace it backwards and see what it's doing downstream and what's doing upstream. So then from there, when you approach your medication toolbox, understanding what all of your medications do, then you can make the best decision for your patient about medication, drug, dose, usage, all of that stuff. So I really just like, as a new grad, look it up on YouTube. So you say you have a patient with a CABG, okay? Google YouTube CABG, like coronary artery bypass graft ×1. Look it up on YouTube and then try to draw what it is. You don't have to get down into like the size of the sutures or the type of any of that, but just what is happening, do a little cartoon sketch, and then that's gonna help you understand what you're doing with your medications and why you're choosing the medications that you are.
And it's going to help you logically think through other things to avoid as well, like not just medication wise, right? So like, for example, a patient with a fresh CABG, it's going to help you understand your blood pressure goals better.
Yeah.
You're not going to understand like why after post-op cardiac surgery, how come my, aortic dissection patients or, the big aortic surgeries, we have really low blood pressure goals for them, right?
Why?
And then maybe after an aortic valve replacement, we can tolerate their blood pressure being a little higher. Why? After a CABG, it's kind of like that's perfect right in the middle spot. It's like it can't be too high or too low, it has to be just right. Why is that? We don't want to blow those delicate suture lines on a CABG, but those
Which is
patients.
why you're never gonna flush your line full of pressors.
No flushing lines full of pressors.
None of that.
None of that nonsense.
None of that.
But it could happen. Just be careful. Anyway, so yeah, you don't want to harm those delicate suture lines, especially once you YouTube what those little tiny sutures look like. You're going to understand why. You're going to go, oh, and then where the blood is coming off. So like a lot of times, one of your jump sites will be your lima, left internal mammary artery, right? And that's already connected. They only have to do one anastomosis, meaning suture site. Copy paste, one little paste site, right? One little jump. And then, the lima to the LAD, like very common way to do it. But if you look at these vessels, you see how big they are, you see how powerful they are, how much blood is pumping through them, and you see how delicate the suture lines are and how they're literally cutting holes in the left anterior descending coronary artery.
Wild.
And then suturing it with this tiny little thread, and you think to yourself, oh my God, if their blood pressure was really high, I bet that thing would blow, and that is very stressful to me. So I am going to be extremely vigilant right now, and that's really important. So YouTubing things, understanding just like the big picture, understanding your pressors, and then you're gonna see like, hey, their blood pressure's high, and that's not okay, this is really urgent. You're gonna know to just cut your norepinephrine in half right then and there, or to bump it down, or to pause it immediately, or like give a fentanyl bolus, or whatever you have to do. Please guys, this is not medical advice, context dependent, right? But you're gonna know to act in that moment rather than like walking away from the patient.
So it comes back to just seeing the big picture. And as a new grad, you often don't see the big picture because you're dealing with surgeries you've never heard of before. You don't understand why you're giving the medications that you're giving. And honestly, you don't know how the medications work. Like it's a triple whammy of not understanding what you're doing or why you're doing it. So if you can just look up the surgery, look up the, or if it's a medical presentation, look up the patient population, look up why you're giving the medication, and then learn more about your tools. And then in the new to ICU membership, we have a whole spreadsheet about Alpha-1, Beta-1, Beta-2, how much each medication works on each receptor site. And then we also we go in depth into the parasympathetic and the sympathetic nervous system.
And like what these receptor sites actually do, right?
Right. We also want to offer support along the way on YouTube and podcasts, just because it's such an adjustment coming to ICU. So, and we really want to provide that sense of community. So follow us here and subscribe. Please comment what you want us to talk about on the YouTube channel. We want to be really interactive with y'all and hear what do you want us to talk about, so we can address that for y'all. And then check out the new to ICU membership. It is on confidentcareacademy.com.
Yeah, so I wanted to add in, it's very easy as a new grad to get overwhelmed with the studying. We're telling you now to look up all this stuff, but we have an entire YouTube episode where we already spoke about like how to balance studying as a new grad, and our new grad tips video, please go back and watch that for further reference. But it's really important that as you're at work, when things come up, a new drug, a new surgery, a new disease process, just keep a running note in your phone, just in your iPhone in the notes section, and then when you go home, on your days off, spend no more than an hour looking that stuff up.
Yeah.
But YouTube, everything. Khan Academy is a great resource. Osmosis is a great resource. A lot of times now there's a lot of articles for free on PubMed.
Yeah,
There's
they're all
just so
free
many
now.
options. So, I really just encourage you guys to just spend a little bit of time on that, but don't go too much.
Also, medical device companies have animations of the surgeries that they do oftentimes on YouTube, and that is a great learning resource. I watched the balloon pump video series probably like 6 times as a new grad.
Get the visual.
And just to get the visual of what was happening, and that was so helpful, just that animation series. It's like 3-minute videos. So like Chrissy said, go back and watch the, I think it's New Grad Survival Tips.
Yeah, New Grad Survival.
Yeah,
That's the one.
So go watch that YouTube video or podcast and then incorporate studying. And the list on your phone is a good life tip just in general.
It's the move.
If you don't know something, write it down and look it up later. That will take you far
Yeah.
in life. And then circling back to what we offer, so we have the New to ICU membership where we dive deep into every single one of these medications, and we have we have case studies, we have lectures, we're getting into the sympathetic and parasympathetic nervous system. That's on the New to ICU membership on ConfidentCareAcademy.com. But we also know that being a new grad or a new ICU nurse is so stressful and it's such a steep learning curve. We all wanted to be here on YouTube and in the podcast as well.
Yeah, so join us on, here you go guys, right? We're gonna put this in the caption below too. ConfidentCareAcademy.com. That is where we have the New to ICU membership. So if you want to dive deeper into these topics, if you want to get more of the details, if you want the resources that Anna's talking about, that is where you're gonna go. You're gonna get more exclusive videos every month where we dive way deeper into these topics. We have a live review session, we have case studies, and we have the handouts for you. So we would love to see you over there as well. But in the meantime, subscribe and stay tuned, and we'll see you soon.
Thanks.